Hello, my name is Vaishnavi Gannison, and I'm a first year internal medicine resident at Creighton University in Omaha, Nebraska. My presentation today is celiac disease as a risk factor for recurrent sepsis. So, starting with the introduction, celiac disease is a chronic small bowel disorder associated with recurrent diarrhea and abdominal pain, triggered by gluten ingestion and characterized histologically by mucosal inflammation, villus atrophy, and crypt hyperplasia. It is found in approximately 0.7 to 1% of the U.S. population, particularly in individuals with other autoimmune syndromes, though it is underdiagnosed in the general population. Sepsis is a life-threatening inflammatory condition typically characterized by hypotension, tachycardia, hypo or hyperthermia, leukocytosis, and elevations in inflammatory markers. Incidence of sepsis in the U.S. is rising, accounting for 1.6 million cases annually from 1979 to 2000, and worldwide a significant proportion of sepsis-associated deaths occur in relation to underlying injury and non-communicable disease. My case report today is about a 66-year-old gentleman with a past medical history of type 2 diabetes, atrial fibrillation, and hypertension, who presented from an outside hospital with septic shock secondary to enterococcal bacteremia. 1 month prior to his admission, he was admitted to an outside hospital for enterococcal bacteremia requiring ICU-level hospitalization, with an additional visit to an outside emergency department for symptoms related to his bacteremia 1 week later. On admission, he was treated aggressively with IV fluids and antibiotics. His admission was complicated by development of atrial fibrillation with rapid ventricular rate, along with repeated episodes of delirium and altered mental status. Further careful history reveals a years-long history of recurrent episodic diarrhea and persistent rash on his chest and hamstrings that had previously not been evaluated. Testing revealed positive tissue transglutaminase antibody suggestive of celiac disease. Further workup and colonoscopy were deferred due to safety concerns with the use of anesthesia in this patient. He was discharged on IV ampicillin and ceftriaxone for possible endocarditis, continued through a PICC line for 3 weeks. So moving on to the discussion and conclusion about this case. Celiac disease has been associated with an increased risk of other autoimmune diseases, pancreatitis, and infections, including but not limited to tuberculosis, influenza, C. diff, and particularly pneumococcal infection. Patients with celiac disease have demonstrated increased risk of sepsis stemming from these conditions. In previous studies, this increased risk was found solely in individuals diagnosed with celiac disease in adulthood. The causative link between celiac disease and increased risk of sepsis has not been definitively established, although proposed explanations have included hyposplenism, increased mucosal permeability, and altered composition of the intestinal glycocalyx. This case illustrates the potential for undiagnosed celiac disease in patients with recurrent sepsis admissions. For this 66-year-old gentleman, his repeated admissions of enterococcal bacteremia were exacerbated by and possibly due to his undiagnosed celiac disease. As celiac disease is underdiagnosed in the United States, it should be kept in mind as a potential complicating factor during hospital admissions for sepsis, particularly as incidence of sepsis continues to rise. And with that, that's my presentation. My references are listed below, and I would like to thank Creighton University and the American College of Physicians for allowing me the chance to give this presentation.